one thing that I read, which was really interesting, right? Even in patients with, post therapy, PT0, essentially, they didn't have any response, they had full response in their bladder. They made a positive note. I mean, it was only a handful of patients, I believe, right? But I think that's an interesting point, right? I mean, I think in prostate cancer for sure, where maybe more and more people are kind of arguing that maybe there's a possibility that node dissections don't really do much. Bladder cancer, there was a recent SWOG trial that came maybe extended lymph nodes may not be as useful as we once thought, right? Contextualize that into kind of the current your data into the kind of the current atmosphere that we're really dealing with bladder cancer now. Like, has it
Yeah,
changed your practice? Like, what do you think?
yeah, and I think I think it's really interesting, especially with SWOG 1011 reading out recently and thinking about the really what is the most thoughtful approach to lymph node dissection and urothelial cancer in general. Obviously, that's a different population. Um, but yeah, that was and again another really interesting finding from this when pouring through the data and analyzing it was that there was a discordance between the response in the primary organ and the response in the nodal metastases that patients had, and we've anecdotally seen that through even the cohort we published. There's been a really interesting just kind of disconnect, and we've seen a lot of patients who have no residual disease in their primary and continue to have disease in their nodes. So I think you could argue that the role of a really thorough lymphadenectomy and targeting sites that were either PET avid or once PET avid could be important. Does that mean you're going to go super high up the retroperitoneum in your dissection? I don't know.
Yeah,
But I think you could argue that a lymphadenectomy, at least as we're learning about kind of
for
this
sure.
group of patients, and it seems like maybe one site in certain patients, based on the tumor biology or the patients or the amount of treatment they got, maybe some sites are more immune protected than others. It could also be the quality of the local resection. If patients had multiple TURBTs and really high
Yeah,
quality TURBTs, they may be more likely to be YPT0 in the primary organ from that, whereas obviously the lymph node metastases would only be treated by the systemic therapy. But yeah, I think that this preliminary data is supportive of the fact that at least while we're learning more about this population and how these patients what we're finding at surgery. I think a really thorough lymph node dissection and if feasible targeting sites that were concerning, even if they're outside of a standard template, is probably important to do if you can do
yeah.
it with, and not putting the patient at risk for a significant increase in morbidity.
Yeah, I mean, I think my takeaway from this was I think there's still a role for lymphadenectomy. I mean, again, 26 patients, we can't make any large conclusions on it, but I
Yeah.
mean, I think, you know, at least how that's changed, the most recent readout, how that changed my practices. I'm not going all the way up to the IMA. I'm not sure there's a really great benefit in that sense, but I'm still doing extended lymph node dissection and may not going as high as I would have maybe potentially thought was needed. But I think that's what is, and I'm sure we'll learn more, hopefully, in your prospective trial in this regard. So, I've just we want you to leave us with some lasting thoughts, right? I mean, this is, provocative data. I think it's important to understand it's very, very specific, retrospective. You guys are coming out with a prospective trial in this area. Give us your final thoughts. Where do you think this field is going to go, and what is this going to look like 10 years from now?
Yeah, great question. I think what I would emphasize is this paper is not the final chapter by any means. I think this is the introduction, right? So we are just starting to learn about this disease state. We're just starting to learn about the role for consolidative local therapy. This was just an effort to sort of highlight and start a discussion about, hey, maybe there's a role for treating the bladder, and whether that's surgery, whether that's radiation. I think that there's a lot more to be learned, and then I think this really highlights how much we don't know, right? So by writing this paper,
Yeah,
we really, I think, are trying to emphasize how many unanswered questions there are, and I think how important it is as a field for us to try and systematically answer those in a prospective fashion. I think there's a lot of work to be done in this space, and our colleagues. So Dan and I are not leading We are not the PIs for that clinical trial. It's actually one of our colleagues in medical oncology, Jake Orme, and one of our colleagues in urology here at Mayo, Para Shah, who are the PIs for that study. And I think it's again, it's sort of the next iterative step in the scientific journey, which is to say, same patient population, patients with metastatic urothelial carcinoma. Let's now do this as a phase 2 prospective clinical trial. Let's have clearly defined endpoints. Let's collect, tissue. Let's collect blood. Let's collect ctDNA at various time points. Let's sort of protocolize this so that we can actually start to understand a little bit more. And then I think ultimately what we really need longer term is randomized data, right? Because at the end of the day, if someone has a favorable response to systemic therapy, the question no longer is, can we do the surgery? I think even just this initial cohort shows that yes, we can do the operation. I think we have to quickly move to the next question, which is the much more important question: should we do it? Yeah. So is there oncologic benefit? Sort of like your Carmina analogy in RCC type of picture. And I think that's where we're headed, right, over the next several years to decade, is to say patients who do well with systemic therapy in the setting of metastatic disease, do we actually offer them oncologic benefit in the long run by treating their bladder and the pelvic lymph nodes? And I think that's the question we're going to have to answer. And then there's a lot of sub questions. How do we select them? What's the best biomarker? What's the best restaging, imaging, or molecularly? And I think that's really where the field's headed.